Good afternoon, everyone. So today is our 13th day of our liver imaging series, and it's my pleasure and honor to introduce Dr. Aya Kamaya. Dr. Kamaya is an associate professor of radiology at Stanford. Can you scroll to the second slide?
Thank you.
Dr. Kamaya is an associate professor of radiology at Stanford University. Look at her picture. You will not imagine that this is her CV. Huge accomplishments over a short time or short period of time. She is currently associate professor of radiology in Stanford, and she's the director of body imaging fellowship. She's also the director of ultrasound in Stanford, and she is our chair of ACR Ultrasound LI-RADS Screening and Surveillance Working Group. She is a member of LI-RADS Steering Committee and member of LI-RADS Writing Group. She is on the executive board of the Society of Radiologists in Ultrasound, currently serving as a treasurer. But watch out, she will become the president in 2021. So we don't need to mess with her, guys. She's the lead author because she's going to be the president. She's the lead author of the textbook Ultrasound of the Abdomen Pelvis with Elsayes, and she's the lead author of the Diagnostic Ultrasound for Sonographers with also Elsayes, and she's the lead author of Ultrasound section of Rad Primer, which is very popular online learning tool used by nearly all radiology residents throughout US and Canada. The introduction can be very extensive, but I think we need to leave some time for her to speak on the lecture. But we are honored and delighted to have Dr. Kamaya to talk about ultrasound screening of hepatocellular carcinoma. Dr. Kamaya.
Thank you, Khaled. It's so great to be here, and I really appreciate everyone joining in. It's a real honor. So let me get started here. Okay, so I'm going to talk about hepatocellular carcinoma surveillance and the ultrasound LI-RADS algorithm. So the last, 12, 13 days, we've heard a lot about LI-RADS in general, mainly focusing on CT and MRI. US LI-RADS is going to come up pretty soon in a couple of days with David Fetzer. But we're going to step back a little bit and talk about ultrasound LI-RADS, which is slightly different. So in case you don't already use ultrasound LI-RADS, I hope that this will be a good refresher and will convince you to incorporate this in your institution. So ultrasound LI-RADS, it stands for Ultrasound Liver Imaging Reporting and Data System. And we provide a standardized system for screening and surveillance ultrasounds in patients who are at risk for developing hepatocellular carcinoma. So, you know, all major hepatology societies actually recommend using ultrasound for screening and surveillance. But interestingly, many of these hepatology societies actually do not provide any guidance as to how to perform the ultrasound, how to interpret the examination, or how to report the findings. So there is a huge void in the management guidelines out there, and so we help to fill this void. And with standardization, the goal is to improve our ability to collect data, which can then hopefully help inform future potential changes. So ultrasound LI-RADS is different from CT, MRI, or contrast-enhanced ultrasound LI-RADS in that the goal is different. So the goal of ultrasound LI-RADS is to detect, but not necessarily to characterize, liver observations in patients who are at risk for developing HCC. That's different compared to what you're trying to do with CT, MRI, or US LI-RADS, where you're using contrast, multi-phase contrast to help definitively characterize focal liver observations and to actually diagnose whether or not that is a hepatocellular carcinoma. So that is the biggest distinction between ultrasound LI-RADS and CT, MRI, and US LI-RADS. So the way we envision how ultrasound LI-RADS fits into the greater LI-RADS universe is that patients who are at risk for developing HCC, they should undergo surveillance ultrasounds every 6 months. And depending on what the ultrasound shows, you can give a score of ultrasound 1 negative, ultrasound 2 subthreshold, or ultrasound 3 positive, and only if you have an ultrasound 3 positive would you then go on to further characterization with a diagnostic multi-phase study. We do acknowledge that some patients may actually undergo surveillance with a multi-phase CT or MRI, especially in pre-transplant patients, for instance. We often do that at Stanford, and so those patients would bypass the surveillance ultrasound and go directly to the CT, MRI, or CUS LI-RADS algorithm. There are going to be some patients who get a CT or MRI or other cross-sectional study for other reasons and may have an incidentally detected liver observation. But if it's not a multi-phase study, that liver lesion may not be fully characterized. And so those patients should then go on to a multi-phase examination. Based on that multi-phase examination, then you would apply the LI-RADS categorization scheme, which we've heard a lot about in the last couple of weeks. So I want to talk briefly about some of the rationale and background of why and how we do screening and surveillance for HCC, and then we will move into the ultrasound LI-RADS algorithm. So as you know, HCC is a cancer of the hepatocyte, and depending on which references you look at, there's a little bit of difference, I guess, in the literature, but from what I can find, it is the 6th most common cause of cancer worldwide, but the 2nd leading cause of cancer-related death. And HCC actually does not occur in everyone. It only occurs in people who have chronic underlying liver disease, with the most common etiologies being hepatitis B, alcoholic cirrhosis, and hepatitis C cirrhosis, although we are seeing an increase in NASH-related cirrhosis as well. Okay, so with a disease that's so prevalent and so lethal, it's really important to perform screening and surveillance to improve survival. And the goal is to try to identify these patients with preclinical HCC when it is potentially curative, when patients may either undergo local therapy for their HCC or potentially a liver transplant. And it has been shown that survival is increased with routine semi-annual, meaning every 6-month surveillance. So we use the word screening and surveillance a lot for HCC, and they're kind of similar terms, but I think it's important to understand the nuance and the difference between the two terms. So screening, this applies to when you apply a diagnostic test to a population that is at risk for developing a disease, but they should have no a priori reason to suspect already having that disease. So it's the first time you apply that diagnostic test. After that patient has been shown to not have that disease, they're still at risk of developing that disease or HCC in the future. So even after that first negative test, you still need to repeatedly test that patient. And so after that first time, you repeatedly apply that same diagnostic test to the same population, but at an interval that's determined by the disease. And so each additional time that you do that test, that is surveillance. So with screening, we detect the prevalent disease, whereas with surveillance, we will detect the incident disease. When we talk about screening and surveillance and what tools we use for that, it's important to understand what are the criteria that we need to meet in order to make screening beneficial. So first of all, the disease that you're looking for needs to be an important health problem, which is true for HCC. You need to have an identifiable target population. It needs to be that treatment of the disease when it is occult is advantageous to treatment of that disease when it becomes symptomatic. So it doesn't help if you identify a subclinical reservoir if it doesn't affect their survival. So if you're able to identify them early and that is advantageous, that's really important. The screening test that you use needs to be cost effective, and that has actually been defined in the early 1990s as costing less than $50,000 per quality adjusted life year gained. That's a threshold that was set a long time ago, and it, despite inflation, it actually hasn't changed over time. So that's kind of a different topic that I will not go into today, but that is the threshold at this time. The test that you use needs to be acceptable to the population and to the provider. And that's a really important thing. Like if the test is too invasive, even if it is a perfect accuracy, if it's too invasive or too difficult to undergo, then that test is not a good test for screening. If you have a positive screening exam or study, then there needs to be standardized recall procedures, and that test needs to have an acceptable level of accuracy. So when it comes to HCC, there are two major screening and surveillance tests available, or most widely used, I should say. The most widely used tests are ultrasound and AFP. So ultrasound is recommended by all hepatology societies worldwide, and the most frequent interval for ultrasound is recommended to be every 6 months. So the AASLD, LI-RADS, EASL, APASL, that's the Asian Pacific Association for the Study of Liver Disease, the Japan Society, the Korean Society, and the Indian Societies all recommend using ultrasound for screening and surveillance. And the reason for that is that ultrasound meets a lot of those criteria, or all of those criteria that are set for what makes a good screening test. First of all, it is widespread in its availability. You can get a high quality ultrasound in almost every country in the world. It's non-invasive, and so it is well accepted by patients and physicians. There's moderate cost associated with ultrasound, so it's a lot cheaper than, say, a CT or MRI. Sensitivity, on the other hand, is what I think is where we receive the greatest criticism for ultrasound. And currently, the sensitivity rates for ultrasound, what is the most accepted range is somewhere between 60 to 94%. You're going to see some papers out there that quote ultrasound sensitivity is lower than 60%, but I caution you when you look at those papers that they are not including pre-transplant patients and child PUC patients, because those patients should not be undergoing ultrasound screening and surveillance, and they will actually lower the sensitivity rates. The other thing I want to point out is that the 60 to 94% sensitivity rate that's quoted for ultrasound is actually very similar to the sensitivity rates that are quoted for mammography in breast cancer. When you use ultrasound as a screening test, the specificity is actually quite high, over 90%. AFP is another screening and surveillance test that is widely used, but currently it's only recommended for use by Asian societies with a threshold of 200 nanograms per milliliter. This has a high specificity, but the sensitivity is only 22%. And so because of the variable performance, it's actually not recommended by all hepatology societies. The AASLD in 2011 actually did not recommend using AFP, but in 2018, they have actually reintroduced AFP as an optional adjunct to ultrasound. I want to acknowledge that there are other screening and surveillance tests that are currently being investigated, including full MRIs, abbreviated MRIs, triphasic CTs, or some sort of combination of the above, as well as ultrasound based on risk stratification. But these are all investigative at this point. None of these others have actually shown improvement in survival yet, but I think that ultimately we will probably come to some sort of steady state with ultrasound and perhaps some other type of surveillance test as well, but that's in the future. I want to talk briefly about why we recommend 6-month surveillance intervals. So that 6 months is not arbitrary. That interval depends on the growth rate of the tumor that you're looking at, not the risk of developing the tumor. And with HCC, most people feel that the doubling rate of HCC is somewhere between 4 to 6 months. So that 6-month surveillance interval actually closely matches or approximates that doubling rate. There's also been studies looking at surveillance intervals for HCC, and there's been a couple of studies that have shown that 6-month intervals does prolong survival compared to 12 months. And so that is probably a better surveillance interval compared to 12 months. But let's, on the flip side, if you shorten it to less than 6 months, there actually has not been any evidence to show that a shorter interval improves survival. So most societies do recommend a 6-month interval. I want to talk briefly about the evidence for why we use ultrasound. Most of the strongest evidence actually comes from outside of the United States, and in particular, most of it comes from China. The largest study out there is, or the strongest evidence comes from China, where they had 19,000 patients with chronic hepatitis B with and without cirrhosis, where they used AFP and ultrasound every 6 months. And although they had a relatively low compliance rate of about 60%, they were still able to demonstrate a 37% reduction in HCC-related mortality. And they think that if the compliance were higher, that mortality rate decrease might actually be better. There's another randomized controlled study with only AFP, and that was also coming from China, and that did not show a change in mortality. And so we think that perhaps that first study with both ultrasound and AFP, we can attribute the majority of mortality decrease to ultrasound. There was a single mass ultrasound screening study in Taiwan, and that demonstrated a 31% mortality decrease. And then there's an older study also from China from the late 90s, where they had 17,920 patients. So all of these are very large numbers. And in this older study, patients who underwent surveillance had 1 and 2 year survival of 88 and 78% compared to 0 for those who did not undergo screening or surveillance. So there's a lot of strong evidence out there, mainly from China, mainly from Asia, that shows that ultrasound screening and surveillance does improve survival. So a lot of people have wondered whether or not we can apply all of that evidence from Asia and apply it to the United States. There's a lot of questions. You know, the underlying liver disease in the United States is quite different from Asia. We have more NASH cirrhosis, we have more alcohol cirrhosis, and the body habitus in the US is quite different. I'm sure, Khaled, you see that in Texas. Unfortunately, there will never be such large randomized controlled studies in the United States, similar to that which has been done in Asia. And the reason for that is that there are ethical ramifications for not performing screening and surveillance in a disease that is so lethal. So in the US, we do have some evidence. It's not quite as strong, but it's still quite good. And what we have now are several large retrospective cohort studies. These have actually come out in the last several years, interestingly. And one of them is actually by Amit Singhal, who gave us a lecture a couple of days ago. So he's a great researcher in this field. So the evidence in the United States has shown that surveillance with ultrasound is associated with detection of early stage tumors. Screening with ultrasound is more likely to undergo curative treatment. You will improve survival with ultrasound surveillance, and there's a 38% reduction in mortality. So I want to briefly talk about the target population for screening and surveillance in the United States. Like I said before, not everybody is at risk for developing HCC, and so it's important that you identify your target population. And in the United States, this has been identified by the American Association for the Study of Liver Disease, and that includes patients who have cirrhosis from any cause. The reason for that is that their incidence of HCC from cirrhosis from any cause exceeds 1.5% per year, and that is considered to be cost effective. In addition, the AASLD also includes non-cirrhotic hepatitis B patients, but not everybody with chronic Hep B, just certain subpopulations in whom the incidence of HCC exceeds 0.2% per year. And so those subpopulations include Asian males over 40, Asian women over 50, African or North American Blacks, or patients who have a family history of HCC. So you might be wondering why the thresholds are different between cirrhotic patients and non-cirrhotic Hep B, and why would we include these non-cirrhotic Hep B patients where their incidence is quite a bit lower for HCC. And the reason for that is that these non-cirrhotic chronic Hep B patients, their life expectancy would be much longer if it weren't for the fact that they are at increased risk of developing HCC. So that is considered to be cost effective. There are other populations where it is uncertain whether surveillance is of benefit. And those populations include non-cirrhotic chronic hepatitis C patients with stage 3 fibrosis, non-cirrhotic hepatitis B patients who don't meet the above criteria, and non-cirrhotic non-alcoholic fatty liver disease patients. So in these populations, it's not wrong to do surveillance. It's just uncertain whether or not it is a benefit. And so whether or not you include those additional patients really does depend on your local and regional preferences. I also want to point out that the AASLD and LI-RADS, the target population is different compared to other countries. And so if you don't live in North America, then you should refer to your local hepatology society's recommendations. There's some slight nuance, some slight differences in recommended populations. But I do want to point out that the AASLD and LI-RADS does not recommend screening and surveillance in patients who have Child-Pugh-C cirrhosis. And the reason for that is that their life expectancy is not long enough to where it would be expected that surveillance would prolong their lives, unless they're waiting for a liver transplant, in which case they should undergo surveillance. But it's not clear what modality is best for those patients on the transplant waiting list. And because it is so critical to identify small HCCs in those patients who are on the transplant waiting list and to treat them and keep them within a certain range, at least at Stanford and probably most institutions, we do typically use MRI or CT in these patients who are on the transplant waiting list rather than ultrasound. But that's not to say that ultrasound is not useful in those patients. We still do ultrasounds because we're looking for other things. We're looking for patency of vessels, flow in the tips, many other things. Okay, so that's a little bit of background about screening and surveillance. Let's move on to the ultrasound LI-RADS algorithm. Okay, so in our ultrasound LI-RADS core, we provide some guidance as to how to perform the examination. We stress that it's important that you use proper technique to optimize and maximize visualization of the liver. So the first thing is that you want to make sure the patient has not eaten for the last 4 to 6 hours prior to the ultrasound to decrease the amount of bile gas that can potentially affect the quality of the ultrasound. You want to optimize the image for adequate penetration to visualize the entire liver and diaphragm. If you can't see the diaphragm, then you can't be sure that you are seeing the whole liver. We recommend you use transverse and longitudinal grayscale views of the liver and look for any focal or diffuse abnormalities in the liver. We recommend that when you look at the portal vein, you use both grayscale as well as color Doppler. And the reason for using both is that if you only use color Doppler, you may obscure small non-occlusive thrombi. So we recommend using both. We leave it optional as to whether or not you evaluate the right and left portal vein branches or the right, middle, and left hepatic vein branches, although at Stanford we do routinely look at those vessels. And then if you identify a venous thrombus, then it is important to try to interrogate that further with color and spectral Doppler, because you can potentially identify tumor in vein or differentiate that from bland thrombus. Although in our algorithm, it does not actually make a difference whether or not it's bland or tumor in vein, bland thrombus or tumor in vein, because both should go on to further characterization with a contrast enhanced exam, but it may potentially affect patient management if you can identify that or differentiate that early. In the Ultrasound LI-RADS core, we have recommended views to be used for screening and surveillance ultrasounds. And we also have views and techniques that are optional. We list them as optional, although we do feel that these optional views can enhance the evaluation in these patients. Okay, so this is the meat of what Ultrasound LI-RADS recommends. So Ultrasound LI-RADS, we recommend providing 2 independent assessments of the whole liver. And I stress that it's pertaining to the whole liver. You don't give a separate Ultrasound LI-RADS category for each observation. The score is for the whole liver. You just give 1 score for each assessment. Okay, so the first assessment is the ultrasound category score, and there's 3 possible scores here. There's ultrasound 1 negative, ultrasound 2 subthreshold, and ultrasound 3 positive, and the ultrasound category determines the follow-up recommendations in these patients. So if you have an ultrasound 1 negative exam, then you would just go on to routine surveillance ultrasounds in 6 months. If you have an ultrasound 2 subthreshold observation, that means that you see something less than a centimeter in size, we recommend short interval follow-up ultrasound in 3 to 6 months. With the caveat that if that finding stays stable for 2 years or longer, then you can consider that to be benign at that point. And then if you see something that is greater than a centimeter on ultrasound, that would qualify as an ultrasound 3 positive examination. And for that, we recommend further characterization with a multi-phase contrast enhanced exam. The second assessment we recommend providing is the ultrasound visualization score. And like the ultrasound category score, there are 3 possible visualization scores. There's A, no or minimal limitations, B, moderate limitations, and C, severe limitations. And the ultrasound visualization score communicates the expected level of sensitivity, but it does not determine follow-up at this time. So this is somewhat analogous to mammography in breast imaging, where the ultrasound visualization score is analogous to the reported breast density, where it communicates the expected level of sensitivity. Like breast density, you take the examination recommendations and realize that there is some variability and sensitivity of the exam, but just because you have dense breasts, for instance, does not mean you automatically go on to future MRIs for the rest of your life. Similarly, the ultrasound visualization score at this time, we're not making any recommendations about follow-up, although this may change in the future. Okay, so let's go through each of these categories in a little bit more detail. So the ultrasound 1 negative exam means that there's no ultrasound evidence of a hepatocellular carcinoma. So there is either nothing or you only see definitely benign observations. So by definitely benign, that can be a simple cyst, focal fat sparing in characteristic places such as around the gallbladder fossa, in a fatty liver. If you have a previously confirmed benign lesion, such as a hemangioma on a prior contrast-enhanced exam, then you can consider that to be benign and negative. And then calcifications like granulomas, those are typically benign. Let's see, so for these, the recommendation is to just go on to repeat ultrasound in 6 months. So here's 3 examples of ultrasound 1 negative exams. The first is a patient who has chronic hepatitis B with no findings, and so no suspicious observations. That's an ultrasound 1 negative exam. The second example is a patient with these flame-shaped hypoechoic areas adjacent to the gallbladder. That's a definitely benign finding, and that's an ultrasound 1 negative exam. And then the third patient, we see this hypoechoic area in the right lobe of the liver that was previously characterized as a hemangioma, and that's a definitely benign finding if it was previously characterized, and so that can be considered to be an ultrasound 1 negative exam. And so for these, we recommend routine 6-month surveillance ultrasounds. Ultrasound 2 subthreshold is where you have an observation that's detected that may warrant short interval ultrasound surveillance. And what we have defined for this is that you see an observation measuring less than 10 millimeters in diameter that's not definitely benign of any echogenicity. And so for these, we recommend a short interval follow-up ultrasound in 3 to 6 months. And again, if it's stable for 2 years, then you can consider that to be benign. So here are 3 examples of ultrasound 2 subthreshold exams. The first is a patient with a 5 millimeter hypoechoic observation in a patient who has chronic hepatitis B. The second is a patient with a hyperechoic observation in a patient with hep B cirrhosis. And the third is a patient with a 6 millimeter hypoechoic observation in a patient with NASH cirrhosis. So you might be wondering why you would not go straight to CT or MRI in these patients who have subthreshold findings. And the reason for that is that a large majority of these actually have no CT or MRI correlates. And even if they did have a CT or MRI correlate, you cannot characterize these as definitely HCC if they are under 1 centimeter. So as Amit pointed out in his lecture, waiting 3 months does not actually change management in these patients. And so for these, the recommendation is to perform a short interval follow-up ultrasound in 3 to 6 months to assess for stability or change. I also want to point out that there is a paper that was presented at RSNA in 2019 by John Millett and his group at University of Michigan, who looked at ultrasound 2 subthreshold examinations, and they found, actually they have a good number on this, which is that about close to 75% of ultrasound 2 subthreshold observations actually had no abnormality on follow-up imaging. 20% were benign, and about 5% actually had a correlate on CT or MRI, as HCC, LI-RADS 3, or other malignancies. So this pretty much validates the recommendation of this short interval follow-up for these patients. Ultrasound 3 positive is where you have an observation that warrants further characterization with a contrast-enhanced exam. So things that meet this criteria include focal observations measuring over 10 millimeters in diameter or greater than or equal to 10 millimeters in diameter that's not definitely benign, or a new thrombus in a vein, whether or not you think it's bland thrombus or tumor in vein. So for the focal observation that measures greater than or equal to 10 millimeters, that can be a solid nodule of any echogenicity measuring over 10 millimeters, or an area of parenchymal distortion, which can present as an area of ill-defined heterogeneity, refractive edge shadows, or an area where you've lost your normal hepatic architecture. So let me show you some examples. Okay, so the first is an example of a patient with an isoechoic observation measuring over 10 millimeters. And this turned out to be an HCC on further contrast-enhanced exam. Different patient who has a slightly hyperechoic observation. You can see on grayscale, there's actually a little bit of posterior acoustic enhancement in this observation, and there's a little bit of internal vascularity. These are findings that increase our suspicion that this is an HCC. However, the ultrasound, even though we're suspicious it's an HCC, we don't have to convey our degree of suspicion because for the purposes of screening and surveillance, we just need to identify these. We don't need to characterize them since we're not using contrast. We leave the characterization to a contrast multi-phase study. In this case, this patient went on to get an MRI, and you can see this lesion has arterial phase, hyperenhancement, washout on the portal venous phase, and washout on the delayed phase. And so that's when you would use the LI-RADS flowchart. And it measures over 2 centimeters. So there's arterial phase hyperenhancement, it's over 2 centimeters, and washout. So that corresponds to a LI-RADS 5 observation. Different patient who has a hypoechoic observation. This is a little bit more ill-defined, slightly different than the prior. Again, we're not trying to characterize these on ultrasound, although I have to say this does look a little bit different than that prior. Not all HCCs look the same. So that's another reason why we leave the characterization to contrast. But in this case, this patient went on to MRI, and you can see on the MRI there is this targetoid enhancement on the arterial phase in the periphery. And on portal venous phase, it's enhancing and continues to retain contrast, and on the delayed phase, retains contrast as well. And so this actually has an imaging appearance. So this is a LI-RADS M categorization, and does not have an imaging appearance of HCC with contrast. And this turned out to be a cholangiocarcinoma. I think that parenchymal distortion is kind of a tough sonographic finding if you're not looking for it. And so that's why we put this in our categorization scheme and try to have a little bit more definition or guidance as to how to identify parenchymal distortion that is suspicious. So here's an example of a patient who has parenchymal distortion. You can see that there is this large area of heterogeneity, but beyond that, we see these refractive edge shadows that are emanating from this large area of heterogeneity. And, you know, in some patients who have severe cirrhosis, they can have a liver that looks kind of similar to this, but in this patient, this area looked different from the rest of the liver, and this actually corresponded to a very large infiltrative HCC. So, and then I want to point out that in this patient, they also happen to have a tumor in vein. So this is an example of where this parenchymal distortion can be quite helpful. Different patient who has a pretty large expansile thrombus in the portal vein on grayscale. When we see thrombi in veins, we want to further characterize or evaluate them, I should say, with color Doppler and spectral tracings. And in this patient with color Doppler, we see that there is internal vascularity and there's arterialized flow that's actually flowing away from the transducer, away from the liver, and that is quite characteristic of a tumor in vein. And so although we don't have to be absolutely certain in all cases as to whether it's tumor in vein or bland thrombus, in this case, we can be quite definitive that this is actually tumor in vein. So here are 3 examples of ultrasound 3 exams. The first is a 4.1 centimeter isoechoic observation in a patient with hepatitis C. The second is a 1.4 centimeter hypoechoic observation in a different patient with alcoholic cirrhosis. And the third example is a patient with hepatitis C cirrhosis where they have this very large area of parenchymal distortion that causes capsular bulging, and there is this thrombus in a portal vein. So for all of these, we would recommend a multi-phase contrast-enhanced exam for further characterization. Moving on to the visualization score. So the visualization score qualifies factors that affect liver visualization or observation detection. And again, this communicates the expected level of sensitivity of the screening exam for HCC detection in that particular patient. I want to point out that the visualization score can be affected by many things. There are intrinsic factors that can affect the visualization score, such as the patient's liver itself, versus extrinsic factors. We see sometimes patients eat right before the exam, and that can affect visualization. Their bowel gas may be in a certain position. They may not be able to lie in a certain way, or maybe they have a ton of ascites. So there are intrinsic as well as extrinsic factors. Some can be reversed or corrected, I should say, and others cannot. So it's really important when you're talking about visualization score, if there is some compromise, that you try to quantify or identify what is affecting that visualization score. So with visualization score, there's 3 possible scores. There's A, no or minimal limitations, where it is unlikely, if there are limitations, it's unlikely to affect sensitivity of that exam. B, moderate limitations, which may obscure small masses less than 1 centimeter, and then severe limitations, which significantly lower sensitivity for even large focal liver observations. Okay, so first, visualization A examples. So it doesn't mean that the exam has to be perfect. It just means that if you have either no limitations or just minimal limitations. And so we have some examples here. The first is a patient with Hep C cirrhosis. Although there's a little bit of beam attenuation, if any, we see very good visualization of the diaphragm and the majority of the liver. So we give that visualization A. The second example is a patient with hepatitis B cirrhosis, and although the liver is somewhat heterogeneous and we see more echoes in it, there's minimal heterogeneity. We still see the liver quite well, and so we would give this visualization A with minimal limitations. And then another example of a visualization A with no limitations. We see the liver quite well and the diaphragm. Visualization B is where there are moderate limitations, and so whatever it is that is causing some mild compromise or moderate compromise, I should say, to the exam, the limitations may obscure small masses, and by small masses we tend to it's kind of understood that small means less than a centimeter. So examples of visualization B include moderate heterogeneity. So this is a patient who has a fatty liver, but it's kind of heterogeneous in the steatosis, where you might not be sure, is that a little hypoechoic area or is that just the liver itself? So that may cause some limitation in identifying small lesions. The second example is a patient with chronic hepatitis C. There's some beam attenuation here, but we're still seeing the majority of the diaphragm. And we are starting to lose a little bit of the dome here, so there are some moderate limitations here. And then This final example of a patient with moderate limitations where we're starting to not see really small portions of the right lobe of the liver because of bowel that happens to be in that location. Visualization C is where there are severe limitations, and these are examinations where I'm sure we've all seen these where we're like, okay, this ultrasound is completely worthless in this patient. I can't tell anything in the liver, and there are many reasons that can cause a very severely limited ultrasound exam. I think it's important to identify these patients because, you know, maybe that patient needs to have some sort of additional management, but in any case, here are some examples. So the first is a severely heterogeneous liver. Here you can see that the nodule or the contour is quite nodular. There's capsular retraction. There are hypoechoic areas and hyperechoic areas. It's hard to tell, is this the liver, normal liver? Is that actually a mass? And it kind of looks like it's just the patient's liver, but it's just hard to tell. And that can create severe limitations in identifying large focal liver lesions. Another example of a different patient with severe limitations. In this patient, they have such severe beam attenuation from their NASH cirrhosis that we're not seeing a large portion of their diaphragm, over 50%. These thresholds between B and C, I think, are a little bit vague, I have to admit, but at this point, these are the thresholds that we have set. I think that in the future, we may be able to provide slightly more explicit guidance. But at this point, if you can't see over 50% of the diaphragm, then you can surmise that you're not seeing a large portion of the liver as well. So this patient has a visualization C exam. Different patient where nearly the entire left lobe is obscured by rib shadow. And so this is also a visualization C exam. So I just want to briefly talk about some of our experience with ultrasound LI-RADS. When we first introduced this was in 2017, we looked at our experience for the first 9 months. And what we found was that the majority of our ultrasound exams were coded as ultrasound 1 negatives and visualization A. So the majority of exams actually have good visualization, and only a minority, 4%, were visualization Cs, 11% were visualization Bs. So, you know, we're at Stanford, and you might be thinking, well, people in California are much skinnier and easier to image, maybe, compared to patients in Texas or the rest of the country. And, you know, that's a valid concern. But at the same time that we accrued our experience, my colleagues at Einstein in Philadelphia, Shuchi Rogers, and at UT Southwestern, David Fetzer, which is in Dallas, Texas, they also looked at their experience. And I was really surprised to see that our numbers are very similar. UT Southwestern and Einstein in particular, they actually, they did have more visualization Bs than Stanford, but their visualization Cs were a lower percentage than Stanford's. And so I thought that was really quite interesting. And there's a lot of good research coming from David and Amit from UT Southwestern looking at ultrasound LI-RADS. So one thing that a lot of people ask is, what should the recommendation be for patients who have visualization C exams? And, you know, it really leaves us feeling quite uncomfortable to just give a visualization C and not say anything further. Especially as radiologists, we want to give some sort of recommendation. So it doesn't quite settle well, and I can understand that feeling, and I acknowledge that. But at this time, I want to emphasize that the visualization score itself does not affect management at this time. So, you know, the reflex is to just go automatically to CT or MRI in those patients who have visualization score Cs. And I'm not saying that that is incorrect, But at this time, there's no evidence that CT or MRI multiphase is cost-effective as a screening and surveillance test, or if it improves survival. So if you imagine, say, a 40-year-old who has one visualization C ultrasound examination for the rest of their lives, they would have to undergo an MRI every 6 months. That's a lot. And so Ahmed, a couple of days ago, talked about how patients who have visualization C, he feels that perhaps a more reasonable strategy is to repeat the ultrasound and see if that visualization C persists, which in his experience, only about 50% had a visualization C on repeat imaging. You know, at this point, we're just trying to accrue the evidence and we're trying to do the research on this. And so at this time, basically for these patients who have poor visualization, the decision to do something else really needs to be made on a case-by-case basis and in a multidisciplinary approach. It's not wrong to do a CT or MRI, but that decision needs to be made weighing the pros and cons in that individual patient. And as as performance and outcomes data are collected, then it's possible that our recommendations may change based on visualization scores, but that will really depend on what the quality and strength of that evidence shows. So in summary, we recommend that you apply ultrasound LI-RADS in at-risk patients in North America, that is defined as patients who have cirrhosis from any cause, and subsets of patients who have chronic hepatitis B. We recommend that you first assign an ultrasound category score of ultrasound 1 negative, ultrasound 2 subthreshold, or ultrasound 3 positive, and that ultrasound category score determines follow-up. We also recommend that you assign an ultrasound
Aya, I think for some reason you got muted. I didn't mute you.
Okay, I'm back.
So
I'm back.
I think
Okay,
we heard
thank you.
we heard till the beginning of assign ultrasound visualization scores. We can repeat this only at this point, number 2.
Okay. Okay, thank you. Okay, so let's see. So you assign the second part of the ultrasound LI-RADS is that you assign an ultrasound visualization score, and there are 3 possible visualization scores of A, no or minimal limitations, B, moderate limitations, or C, severe limitations. And the ultrasound visualization score, communicates the expected level of sensitivity, but at this time does not determine follow-up officially. So I just want to acknowledge the entire ultrasound LI-RADS working group. I'm the chair of this working group, but we have many amazing members, really smart people from around the world, around the country, that have contributed to this algorithm. And the algorithm may seem simple to you, but we actually went through multiple iterations of the algorithm before we came out with our official algorithm. So everybody really put their heads together. We have new members as well since we first put out our algorithm. And so at this point, we think that future research does need to be performed, and perhaps we'll come out with modifications in the future based on some of the feedback that we receive. So I welcome any questions or comments, and thank you so much, Khaled, for inviting me to give this presentation.
So thank you very, very much, Aya. That's a great lecture. We all enjoyed it. I think I already get some feedback on my phone text messages.